Hello, I'm Dr. Kimberly Ford. On behalf of CMEO Outfitters, I'd like to welcome you and thank you for joining us for part two of a three-part CMEO Pharmacist Central educational series entitled Patients with Hepatitis B, Medical Comorbidities That Can Impact Treatment and Prompt the Provider to Switch. The CMEO Pharmacist Central series is supported by an educational grant from Gilead Sciences. As I mentioned, I'm Kimberly Ford. I'm a hepatologist, associate professor of medicine in the section of hepatology, Department of Medicine at Temple University Hospital at the Lewis Katz School of Medicine in Philadelphia, Pennsylvania. I'm very happy to welcome Dr. Christina Madison to the program. Dr. Madison is the founder and CEO of the Public Health Pharmacist. She's also an associate professor of pharmacy practice at Roseman University of Health Science College of Pharmacy in Las Vegas, Nevada. Welcome, Christina.
Thank you so much for having me. I'm very excited to be giving this presentation with you today, Dr. Ford.
Awesome. So let's begin with our learning objective, which is to partner with patients with hepatitis B virus and their healthcare professionals to support therapeutic decision-making in the presence of renal and bone comorbidities. To review the goals of treatment, they include to impact the natural history of hepatitis B virus, firstly by suppressing hepatitis B viral replication, reducing progression to cirrhosis, reducing other liver-related complications such as the development of hepatocellular carcinoma and need for liver transplantation, and of course, thereby impacting long-term survival. The schematic to the right outlines some of the laboratory markers which are used to determine treatment success, including an undetectable hepatitis B DNA, and of course, loss of hepatitis B E antigen, and the gold standard, which is really loss of surface antigen, which is labeled seroconversion. So pharmacists really play a pivotal role on the collaborative healthcare team in helping to achieve both these short and long-term treatment goals. So I think at this juncture, it would be wonderful to have Christina do a brief refresher on hepatitis B screening and vaccination schedules. We're going to start first by reviewing the U.S. Preventive Services Task Force, or USPSTF, recommendations.
As you mentioned before, obviously we want to make sure that the most appropriate individuals are being screened for hepatitis B virus. So currently the USPSTF recommends screening for hepatitis B viral infection in adolescents and adults at increased risk of infection. So this currently includes any persons born in countries or regions with a high prevalence of infection, which is defined as greater than or equal to 2%, such as Asia, Africa, Pacific Islands, and parts of South America. U.S.-born persons not vaccinated as infants whose parents were born in regions with very high prevalence, which is defined as greater than or equal to 8%, as well as those who are HIV positive, those who are currently engaging in injection drug use, individuals who are men who have sex with men, and household contacts of sexual partners of persons with hepatitis B viral infection. Additional at-risk populations that the USPSTF also recommends should be screened and are part of our CDC and ACP guidance include individuals requiring immunosuppressive therapy, anyone with end-stage renal disease, including those receiving hemodialysis, individuals with elevated AST and ALT, infants born to a hepatitis B surface antigen positive mother, donors of blood, plasma, organ or tissue or semen, and then those persons who are the source of blood or bodily fluids, inmates in correctional facilities, persons with hepatitis C viral infection, and last but not least, persons with multiple sex partners or histories of sexually transmitted infections.
So Dr. Madison, in addition to screening, hepatitis B vaccination should be a primary objective for individuals at risk. Who are at-risk individuals that pharmacists may want to open up a discussion about vaccination status?
So that's an excellent question, Dr. Ford. And as you can see, our ACIP recommendations include those adults who may be needed to get additional screening or more vaccinations for hepatitis B vaccine. So that includes those high-risk individuals that I just outlined previously. So those who may come in contact with a pharmacist and may need additional vaccination are those who have a sex partner who has hepatitis B surface antigen positive, those who have sexually active persons not in a long-term mutually monogamous relationship, persons seeking evaluation or treatment for a sexually transmitted infection, and again, that MSM population that we spoke about earlier, or our men who have sex with men. So that really encompasses those who have a sexual risk or risk of exposure because of behavior. And then those who have a history of current or recent injection drug use, we also want to make sure are up to date with their vaccination. And this also includes any household contacts, residents and staff of facilities for developmentally disabled persons, healthcare public safety personnel at risk for an exposure to blood or infectious contaminated bodily fluids, individuals who are receiving hemodialysis and pre-dialysis, including peritoneal dialysis and at-home dialysis patients. And then also, this is a big one because we see so many of our patients with diabetes. Any individual who has diabetes mellitus who is less than 60 or over the age of 60 at the discretion of the treating clinician. And so again, we are really trying to focus on individuals who have that risk and could greatly benefit from vaccination. So we also want to make sure that we encompass a few other individuals who may also benefit from vaccinations. And this also includes our ACIP recommendations for international travelers to countries with that high prevalence or intermediate prevalence of hepatitis B virus, which we mentioned earlier. So Asia, South America, and then persons with hepatitis C viral infection, those with chronic liver disease, including but not limited to cirrhosis, fatty liver disease, alcoholic liver disease, autoimmune hepatitis, as well as those who have AST or ALT that's greater than 2 times the upper limit of normal. We also have those individuals that are currently having a positive HIV status, individuals who are incarcerated, who may be engaging in, say, illegal tattooing or engaging in injection drug use, and then other persons seeking protection from hepatitis B viral infection, even without an acknowledged or specific risk. And I think that's super important to mention, that that self-identified risk is all we need from a patient. If they are stating that they want protection for hepatitis B viral infection, we need to be providing vaccination.
So, Dr. Madison, let's focus our vaccination discussion on adults. What are the available vaccines and their respective schedules?
Absolutely. So we are very lucky that we have multiple vaccine presentations to choose from. They include our Energix B, which is recommended for all ages, including infants. We have our Heplisav B, which is only recommended in adults 18 years and older, not recommended for use in pregnant women. We also have Recombavax HB, which is also indicated for all ages. We also have some combination products, which are very useful, that protect against both hepatitis A and B. So we've got the Twinrix bivalent inactivated hepatitis A and B vaccination, which can be utilized. It's also available at a accelerated schedule for individuals who may be engaging in international travel. So you can vaccinate them at 0 and 7 days, and then 21 to 30 days, and then a booster at 1 year. So let's go ahead and talk in a little bit more detail about this vaccine schedule. So let's go ahead and start with our single antigen hepatitis B vaccines, which include Heplisav B, Energix B, and Recombavax HB. So as you can see here, our first vaccine that's available for your 18 and up is our Heplisav B, and we can vaccinate you with 2 doses 4 weeks apart, which is a great benefit to this vaccination. We also have Energix B, which can be provided at 0, 1 month, and then at 6 months to complete the series. And then if you have someone who is currently receiving hemodialysis, it's this schedule here where we would add an additional dose at 2 months and then again at 6 months. So a total of 4 vaccinations for complete series. And then our Recambavax HB, again, very similar schedule as our Energix V, which is going to be 0 at 1 month, and then the final dose at 6 months. And then last but not least is our Twinrix, which we talked about earlier. So 0, 1 month, and 6 months. Or you can do that accelerated schedule that we discussed earlier, which would be 0, 7 days, and then 21 to 30 days with a booster dose at 1 year.
Great. Dr. Madison, let's switch gears just a bit to talk about hepatitis B treatment, and in particular, who and when to initiate treatment. While the American Association for the Study of Liver Diseases, the AASLD, has detailed guidelines for the management of chronic hepatitis B infection, management or treatment of hepatitis B does not have to be driven by specialists, especially when such expertise may not be readily available. So the guidance, or the simplified approach that's presented on this slide, comes out of work from the Hepatitis B Primary Care Work Group, which is a multidisciplinary panel of national experts. And they published this simplified guidance specifically for primary care providers. So this chart comes from the guidance document that was published in February of 2020. And I think that there are some key things to point out. So you need some key pieces of information about your patient. So the first is whether they have a history of cirrhosis. That could be established by biopsy if they've had that in the past, by abdominal imaging, or by other non-invasive assessments of hepatic fibrosis. So that's the first piece of information to know. The subsequent 2 pieces of information to know are the hepatitis B DNA as well as the ALT. So we're going to talk a little bit about what we now consider a normal ALT in the next slide. But I do want to point out the fact that the ALT range is probably going to be a little different from what providers are used to. We'll talk about that in a minute. The AASLD guidance also requires that there's an assessment of hepatitis B antigen as well as antibody. That is not required here in this simplified guidance. So if we take the first row of the chart here, so this applies to all patients with chronic hepatitis B infection who have a history of cirrhosis. They can have any hepatitis B DNA level and any ALT. So that means a normal ALT or an abnormal ALT. And the guidance here is to treat with antiviral medications. In addition, there's going to be monitoring of the hepatitis B DNA and the ALT every 6 months. And for routine cirrhosis care, such as the performance of an upper endoscopy for screening of varices, and for hepatocellular carcinoma surveillance, individuals should be following with either a gastroenterologist or hepatologist. Additionally, all patients with decompensated cirrhosis should really be following with a hepatologist and a determination made as to whether liver transplantation evaluation is required. Going on to the next row of our chart here, this refers to the patient who is non-cirrhotic, who has a high hepatitis B DNA level, and they have an elevated ALT. Again, we'll talk about what an elevated ALT is. And the recommendation, again, is to institute therapy with antiviral medications. Here we can see this is the patient with elevated hepatitis B DNA and a normal ALT, and that patient will be monitored every 6 months with the hepatitis B DNA and the ALT, and a fibrosis assessment to be conducted every 2 to 3 years. In the last row of this guidance, we see here people with a low hepatitis B DNA, so less than or equal to 2,000 international units. If they have an elevated ALT, the thought is really that we should be ruling out other forms of liver injury. And if the ALT is normal, that we should be following patients serially. So I think that this is a great simplified approach. It really helps to break things down, and it really means that some of the treatment of chronic hepatitis B infection does not have to occur in the setting of having a specialist available.
So what are normal ALT values in healthy adults? So, Kim, the simplified approach to treatment as well as the AASLD guidelines refer to ALT levels as 2 times the upper limit of normal. Is there an easier way to remember what that really translates to?
Sure. On this slide, we see a great representation of this. And I want to give the viewers a little contextual background regarding how we now determine what is a normal ALT. So when I was training, we would actually look at the upper limit of normal range for the particular laboratory that determined the ALT value. And what we've come to appreciate is that normal reference population perhaps included patients that had underlying chronic liver diseases that weren't appreciated. And in fact, there are also linear relationships between ALT and body mass index and ALT and gender. So how we've come to appreciate what's a normal ALT now is a bit more refined. So we don't just use an underlying population of who we perceive to be healthy individuals. Now there's also a determination of whether there's perhaps underlying liver disease that's not appreciated in determining that healthy cohort. And so many studies have determined that a normal ALT for a woman is 19 and a normal ALT for a man is 30, which is certainly much lower than, when I was training. I think a good rule of thumb is that anything over 25 for women and anything over 35 for men is considered abnormal. The other thing that I want to point out is that patients with a normal ALT can certainly have significant underlying liver disease. We have seen this in our experience with hepatitis C infection, of course, chronic hepatitis B infection, and other chronic liver disease processes such as hemochromatosis. So you shouldn't be fooled into thinking that a normal ALT means that there's no underlying liver disease. Lastly, we also understand now that an elevated ALT is associated with adverse liver outcomes. So really determining what that normal ALT is and treating to that is pretty important.
So what are some of our treatment options for these types of patients, Dr. Ford?
So the key treatment options include the highly potent antiviral therapies that we see here displayed on this slide. So we have entecavir, we have tenofovir disopropyl fumarate, which I will call TDF intermittently throughout the talk. And there is also tenofovir alafenamide, which we call TAF or TAF. Certainly, interferon is one of the medications that can be utilized to treat chronic hepatitis B infection. That tends to be in younger patients who want a finite duration of therapy. They're not interested in prolonged or lifelong therapy. And certainly, there are adverse events that can be associated with interferon use. So we're not going to talk about that specifically today, but certainly in clinical practice, these are the 3 agents that are utilized. Entecavir is started at a standard dose of 0.5 milligrams once daily. For those patients with decompensated liver disease, 1 milligram once daily is the recommended dose. And entecavir can be taken 2 hours before or after food. There are certain side effects associated with entecavir. These include fatigue, dizziness, nausea, headache, and are reported in over 3% of those patients on this medication. A dose adjustment is required if there is underlying renal dysfunction. And also for patients in whom lactic acidosis could be a concern, that should be evaluated promptly. For the TDF preparation of tenofovir, it's 300 milligrams once daily by mouth. This can be taken without regard to food. Again, we see some GI side effects, nausea reported in 9% of patients. Post-marketing surveillance has identified some adverse events associated with therapy. They include nephropathy, Fanconi syndrome, osteomalacia, and of course, lactic acidosis, which I had mentioned with entecavir. There's also a dose adjustment here in the setting of renal dysfunction. And it's important to monitor for renal health and bone health while patients are on the TDF preparation of tenofovir. And then lastly, the TAF preparation is 25 milligrams by mouth once daily, and that's taken with food. Again, we see some of the same side effects emerging, so headache, lactic acidosis is also of concern here. This tends to be the preferred agent for those patients who already have some renal dysfunction at the time of initiation of therapy. We'll present a bit of data later on in the talk to suggest that if your patients have bone disease, osteopenia, osteoporosis, that perhaps they should be initiated on the TAF formulation of tenofovir as well, as there are improvements that are seen in bone health while patients are on that preparation. So this is a really nice summary slide that goes over the table, but differentiates those patients without cirrhosis versus those patients with compensated cirrhosis and decompensated cirrhosis. And I think the important take home from this table is that tenofovir and entecavir appear in the preferred column for each of these disease states. There's some other medications that are listed, including adefovir, lamivudine, talbibudine. These are alternative or non-preferred agents. So for most patients that you're going to see in the office who meet treatment guideline or treatment parameters, they would be initiated on one of these three medications. On the table, there's a mention of pegylated interferon. Again, this is for younger patients without cirrhosis who may want a finite period of treatment. So, Dr. Madison, as with any chronic disease, chronic hepatitis B doesn't exist in a vacuum. Let's shift gears to talk about comorbid conditions that may impact treatment decisions.
Absolutely. And just as a friendly reminder for those great charts that you had earlier, these slides are available for download for your reference, because that's some really amazing information that you just shared. So when we take a look at the impact of medical comorbidities in our patient population with chronic hepatitis B, current estimates suggest that only a third of chronic hepatitis B affected persons in the U.S. are aware of their diagnosis, and only a fraction are likely to have be in care and in treatment for early stages of their disease. And as a result of often delayed diagnosis and treatment, patients with chronic hepatitis B virus are presenting at an older age and are more likely to have liver and non-liver comorbidities that can further complicate their treatment course. So we take a look at this particular graphic. As we can see from the graph below, this is comprised of both commercial insurance and Medicare patients. And when we look at this, we see that we are overwhelmingly getting more chronic medical conditions as people are progressing through their disease state. It includes things like cardiovascular disease, diabetes, hyperlipidemia, hypertension, as well as renal impairment, which we know those with chronic liver disease often end up having some semblance of, hepatorenal failure.
Also, I thought that the study was interesting in that there was an increase in comorbidities over the age range of the patients who were included.
Absolutely, I completely agree.
So, Dr. Madison, how prevalent is osteoporosis in chronic hepatitis B?
Well, if we take a look at this particular graphic, we can see that over time, we're actually seeing a lot more patients, especially those who are not maybe getting as advanced care or maybe not going in for chronic checkups. For our Medicaid population, maybe they're not accessing the healthcare system as frequently. We are seeing that a lot of those patients are progressing to osteopenia and osteoporosis and potentially leading to a fracture. So that's what we're trying to avoid. And obviously, having chronic liver disease itself potentially could be a risk factor for poor bone health. But then when you put on top of that some of our treatment modalities, that may be also predisposing them to bone health issues. So we are seeing a rise in our osteopenic, osteoporotic, and fracture risk associated with chronic liver disease associated with hepatitis B viral infection. We are also seeing instances where individuals are having challenges with chronic kidney disease as well, which we did know is the case for those with chronic liver disease. And so, again, very similar to the previous graphic, maybe a little bit more on par with both our commercial and our Medicare patients combined, seeing that over time, we are seeing more chronic kidney disease. But for sure, for our Medicaid patient population, which may have other chronic medical conditions that may be contributing to this, we are seeing a rise in chronic kidney disease, which may mean that we will choose a different treatment that may be less impactful on both their bone and kidney health. So when we take a look at possibly switching from a drug that may cause more issues with bone and renal health to one that causes less issues with bone and renal health. And again, not to go into the weeds, but when we look at these drugs kind of on a pharmacokinetic basis, you see that tenofovir disoproxil fumarate, or TDF, there's more of the drug that gets into the periphery versus those target tissues, versus when we look at TAF, you have less drug needed to get into the correct space and to impact that viral load, and therefore you have less of an impact on some of those peripheral tissues, which include our bone and our renal health. So again, when we look at the switch data here, in particular looking at both hip and spine, you see that we do have a pretty marked improvement when we switch from the TDF to the TAF medication. And this was at week 96 when we're looking at the potential risk for hip and spine fracture.
For the audience, this data comes from a study that was presented in 2020 looking at patients with hepatitis B, chronic hepatitis B infection. Some patients came into the study and were switched from TDF to TAF. Other patients remained on TDF for the duration of 96 weeks. And as Dr. Madison was saying, there was an improvement in bone mineral density in those patients who actually switched from the TDF preparation to the TAF preparation. We also see an impact on renal parameters during the course of this study. So if you look at creatinine clearance, there was an improvement in creatinine clearance in those patients who switched from the TDF preparation to the TAF preparation of tenofovir, and in other parameters of kidney function. So this is beta-2 microglobulin. So this is great data now that we have here to suggest that TDF and TAF are non-inferior. So as far as viral outcomes were concerned, they were pretty comparable, but TAF really having a favorable impact on bone health and kidney health in the context of this study. So Dr. Madison, the pharmacist sees the patient much more frequently than the physician. Thinking about a patient on antiviral treatment, what are some counseling and teaching opportunities that pharmacists can take advantage of when seeing patients when they come in for their refills?
Absolutely. I completely agree with you. As during our current pandemic, we have realized the importance of the accessibility of a pharmacist, with, over 80% of all adults being within 5 miles of a pharmacy. So I completely agree with you. And so with that being said, there are some things that we can help with because of those frequent visits for refills. And then also, if the patient isn't coming on time for their refills, trying to decide, what can we do to help them with some of those adherence challenges. So the number one thing I would say that we can help with as pharmacists is the drug-drug interactions, especially when it relates to things that patients can get in the self-care aisle, right? So those OTC medications and supplements that they don't really consider to be medications can oftentimes interfere with our hepatitis B treatment modalities. And so some of the bigger culprits here will be things like milk thistle, some of the liver supplements, creatine supplements. Those are the things that, the patient thinks, innocently aren't going to cause any challenges, but really they don't understand that anything that you put in your mouth on a regular basis and into your body could potentially, cause interactions with your current treatment therapies. And so we also want to make sure that we're partnering with other healthcare teams to optimize our treatment of our patients. Because again, we don't do these things in a silo or in a vacuum, right? We're all doing this together, and it's that team-based interdisciplinary care that really helps to make sure that the patient is getting what they need and the most optimal patient care we can provide. So we also want to have that opportunity to discuss things like alcohol and substance use with our patients, which can be a difficult conversation, but we do want to make sure that we are having that open and honest discussion, because these are things that they may not be discussing in the doctor's office. Oftentimes, some of these medications require prior authorization, and so navigating that insurance challenges sometimes is definitely something that the pharmacist can play an important role in, as well as helping patients to understand what's on the medication label. So providing them with education about any food requirements that may be part of the directions that their medication has, and then any safety concerns that they may be thinking about or have questions about. Ultimately, we want to address any of the questions that may not have been able to be addressed during their primary care visit or their visit with their provider, because we know your time is limited, and we want to make sure that all of their questions are answered. As well as the issue with adherence, which I brought up earlier. So if they aren't coming back for that 30-day refill on time, really talking with them about what things are going on in their life that may be causing them to have challenges with taking their medication as directed. And then last but not least, recognizing that there are social determinants of health that may impact treatment and adherence, which include things like transportation, perceived, systemic biases or inherent, challenges because of their race, their gender, or their ethnicity. All of these things combined impact their ability to potentially get to the pharmacy and to get their medications on time.
This has been a great discussion, Dr. Madison. So before we head into questions, let's summarize our discussion with our SMART goals: specific, measurable, attainable, relevant, and timely. This is what we hope that our audience will take away from this presentation to apply to their clinical practice. The first of which is to partner with patients to help them better understand their hepatitis B infection, keep a watchful eye on patients' use of over-the-counter medications, supplements, and medications for comorbid disorders that might interact with their hepatitis B antiviral treatment. And lastly, communicate and collaborate with healthcare providers about patients' hepatitis B treatment plan to optimize outcomes. Dr. Madison, with that, I think it's time for us to let our audience join the conversation and ask some questions.
I can't wait.
So good afternoon. We already have a number of questions in the chat box, so we're going to go ahead and dive right in. So firstly, to Dr. Madison, there was a question about Intergix HD and how it compares to the classic form of vaccination.
Yeah, absolutely. So, obviously, that particular formulation, we're specifically targeting the pre-dialysis and hemodialysis patient population in order to prevent hepatitis B infection. And so, the key here is that obviously, if you do have one of those patients that has that indication, is making sure that they get the full series on time. So, right now, the recommendation is very similar to what we use for the non-HD product. So it's still 0, 1, and 6 months. But again, we just want to make sure that the patient is not left unprotected. So providing them with some of those reminders, making sure that they're coming in for that dosing, and even potentially providing them with the vaccination at the time of their dialysis appointment. All of those things help with those barriers to care. But again, very great question, and I appreciate the vaccine, connoisseurs out there wanting to know the differences between the formulations. So thank you again for the question.
There's another vaccine question that I have for you, Dr. Madison. So the CDC just released guidance about giving other vaccinations with COVID-19 vaccine. And so that's new and hot off the presses. But would you like to speak to not only that recommendation, but the risks of Hep B vaccination and needle sticks during COVID-19 vaccination?
Absolutely. Yeah. So hot off the presses. And then ultimately, just want to remind people that when we look at our vaccine landscape, prior to COVID-19 vaccinations, we knew that simultaneous vaccination administration was recommended for pretty much all vaccinations. And so when that recommendation for the 14 days came out, it was really in an abundance of caution. And now that we are starting to vaccinate our adolescent population, we didn't want there to be any additional barriers to them getting up to date with their adolescent vaccines. And so that's when the initial ACIP recommendation for simultaneous vaccination administration came out with co-administration with COVID-19. And now they are expanding that to all individuals who are receiving COVID-19 vaccines, which is really important, especially as we move into flu season. And then the other question about the potential risk for hepatitis B infection with needle sticks, because of the fact that we are giving out so many vaccinations, is just something to remember. Most pharmacists that provide vaccinations are recommended to at least have 1 dose of hepatitis B vaccination before they start doing their vaccination programs. And ultimately, we want all of our immunizers to be fully protected against hepatitis B. And so the vaccination in some cases, obviously is the best possible prevention, but really making sure that you're utilizing those safety devices and those OSHA approved needles in order to prevent a needle stick.
So there was another question that came into the chat about receptivity of discussions initiated from pharmacists regarding hepatitis B treatment. So first, Dr. Madison, I'll have you talk about your experience, and then I'll talk about how I feel about those interactions.
So I mean, from my perspective, I feel like I have a very open and honest dialogue with the providers that I work with, and so when we're talking about those treatment discussions, it's not something that I would consider to be adversarial. However, I am aware that there may be some instances where some of those recommendations may not be as welcomed as others, and that's okay. But I think the biggest thing is just, developing that plan for your patient, really looking at pros and cons, risk and benefit to addition of any therapies. But ultimately, if we can provide vaccinations, that's obviously going to be the best result before they become infected and before we have to chronically manage their disease state. So.
I was going to say when I approach treatment in hepatitis B patient, I mean, I have many discussions with my pharmacist here in house and discussions with pharmacists outside of the institution as well, just about treatment, how we can best optimize treatment. There are often concerns about insurance clearance for a particular agent. So I find myself engaging the pharmacy staff all the time, and I really value the input. So I would say, please don't feel like you are bothering us. Please come to us. We need your help, and we value your input very much. So thank you, and continue to do so. I think it's only to the benefit of your hepatitis B patients. Sort of talking about how we approach patients, a question came in the chat box about stigma and minimizing stigma from a pharmacist perspective. So I was hoping, Dr. Madison, you could give us some insight in that regard.
Yeah, so one of the things that I was able to assist with kind of earlier on in my career is that I worked very closely with the AAPI community because of the fact that we do know that hepatitis B disproportionately impacts that population. A lot of our chronic cases here in the United States are from people who came from other countries where they don't have as robust of hepatitis, perinatal hepatitis programs, because obviously we know your risk of developing chronic hepatitis is higher if you're perinatally exposed versus later on in life. And so just really getting out in the community and talking amongst the AAPI population, talking about why it's so important to get tested, because you may not even know that you have it. It's no fault of your own. That there should be no stigma associated with it. It's just really about knowing your status. And then if you aren't infected, making sure that we talk about the importance of vaccination. And so I think really meeting the patient where they are, talking with them within their own cultural constraints. And then obviously, when we can, providing information in language, especially when we deal with the AAPI community, we know that some of them may not be native English speakers. And so providing information in language is super important as well.
Great. So there are some questions now about treatment. Firstly, there's a question in the chat box about pegylated interferon, which I must admit I have not used for the treatment of hepatitis B infection. Certainly when we were treating hepatitis C infection with a backbone of interferon, I used it in that setting. Dr. Madison, have you seen pegylated interferon used in the treatment of chronic hepatitis B?
So the instances that I've seen it's been in pediatrics, and again, more so in those who have significantly higher viral loads. But in theory, obviously, it could be used with adults as well. But considering the risk versus benefit, and then the adverse effects associated with that product, the marked depression, people just feeling very fatigued. It's just not a very pleasant drug course. And so
well, it looks like we lost Dr. Madison temporarily, but I can agree that interferon was a pretty difficult treatment regimen to tolerate when we used to use it for chronic hepatitis C infection. And so I don't usually use it in the context of chronic hepatitis B infection, but certainly for younger patients who would like a finite course of therapy, it's important to think about pegylated interferon. I tend to use tenofovir and entecavir. They're highly potent agents when I am making a decision about initiating treatment. Just going back to some of the questions here in the chat, there was a question about, actually two questions about how we use the hepatitis B E antigen and E antibody data and how that figures into our treatment algorithm. And so in the context of this particular series, we presented a simplified version of how we would approach treatment, which is a model or an approach that has been decided upon by experts in infectious diseases, hepatology, et cetera. And that approach is now taking out additional testing like the hepatitis B e antigen to make some of those treatment decisions. Certainly from a hepatology perspective, we've been dependent on not only the hepatitis B surface antigen, but also the hepatitis B e antigen status, whether it's positive or negative. And so there's a question here in the chat about somebody having surface antigen positivity, a Hep B DNA of 7.9 million, ALT 2 times the upper limit of normal. They have Hep B e antigen negative status and E antibody positive status. And I would say because this person is both Hep B e antigen negative, they have a high hepatitis B DNA, so that's greater than 20,000 international units, and an an ALT that's 2 times upper limit of normal, that person would be eligible for treatment. The ultimate problem, though, when we initiate treatment is that treatment tends to be lifelong. And so meeting some of those endpoints, and particularly a very important endpoint, which is developing surface antibody positivity, so losing your surface antigen, doesn't happen very often. And so we are committing people, and sometimes very young people, to a long duration of therapy. So we consider the initiation of treatment very carefully. We certainly don't want to do that early, as we know that there are adverse events that can be associated with therapy. Going back to another question that appeared in the chat, there was one question from a participant about whether the treatment of hepatitis B with antivirals can protect patients from hepatocellular carcinoma. I think it's an absolutely great question. We do see a decrease in the rates of HCC. Just like when we eradicate hepatitis C infection, we do see a decrease in rates of HCC, but that rate is not zero. So in those patients, we continue to get our HCC surveillance. So that's some type of abdominal imaging, so abdominal ultrasound every 6 months. With or without alpha fetoprotein. So I think it's important to note that the rate does decrease, but you're still going to have to screen for HCC in that setting. Likewise, if patients are meeting some of the treatment endpoints, so say for instance, they seroconvert and they lose surface antigen and they develop surface antibody, there's still a very low risk of HCC, but a risk that's present. So it's important to continue HCC surveillance in that setting. Going back to the initiation of treatment, there was another question in the chat, and the question is about if a patient was infected with hepatitis B when they were young, at a very young age, they didn't know it, what treatment makes most sense for them if they're now a teenager. And that person may not need treatment at all. And so again, we would have to determine whether they meet certain criteria for being initiated on treatment. So that would be an elevated ALT, so greater than 2 times the upper limit of normal, and an elevated hepatitis B DNA. So they would have to be followed closely. And again, depending on whether a finite course of therapy is desired, then a treatment decision could be made based on that information. We have Dr. Madison back here. Welcome back.
Thank you so much. Technical difficulties, right?
Well, right on cue, though, because there's a question in the chat about over-the-counter medications such as PPIs and NSAIDs, and perhaps explaining some increase in rates of CKD and bone comorbidities over time. So maybe you could speak to some of these over-the-counter medications.
Yeah, absolutely. I think this is a big thing that we've seen, especially as a lot of these products have gone over the counter, right? So, like a lot of the PPIs are over the counter now.
Mm-hmm.
There's even some of the allergy medications that are now over the counter that were previously not over the counter. And so, with that being said, I think, the biggest thing for me as a pharmacy professional, as well as for those out there that are partnering with pharmacists, is that every patient, you should do a full, what we like to call a brown bag, right? So the patient brings everything that they take by mouth on a regular basis in a paper bag, right? They bring it with them, and then you go through everything. And the first thing that we should do is do a drug-drug interaction profile on all of those medications, as well as looking at things that are over the counter that may be either interacting with their prescription medications or potentially duplicative with their prescription medications. Because a lot of times what ends up happening is that one doctor will discontinue something, another doctor will start something else, and then they're not talking to each other. And so really the only place that we see everything being listed out is at the pharmacy, obviously if the patient goes to just one pharmacy, right? And so I think that's our responsibility as pharmacists to be able to provide that information and that, that thought process. But in particular, when we think about things like the PPIs, which can increase your risk for osteopenia and osteoporosis because of the decrease in the acid, causing decreases in the absorption of things like calcium and vitamin D from your diet. And so in addition to that, with using NSAIDs, that can also cause kidney injury, in addition to your liver disease, potentially causing hepatorenal failure. And so all of these things combined, we really need to look at risk versus benefit, right? And so the reason why these people are taking NSAIDs is for just, over the counter reasons for like pain relief. Let's think about topical options. They have Valtorin, which is a topical NSAID now that's extremely effective. So let's think about alternatives to some of those oral agents instead of, packing on more and more OTC products that potentially could interact with your hepatitis treatment.
I would also say that I think that acetaminophen has gotten a bad name as well. I have many patients who come in and say to me, I have a liver problem. I can't take any amount of acetaminophen. And I try to dispel the myth that they can take some, they don't want to take too much. And obviously, if they have cirrhosis, they should limit that to less than 2 grams in a day. But I think that really acetaminophen has gotten a bad name over this, this period of time.
I agree with you. As somebody who has like a horrible allergy to NSAIDs, I'm like, no NSAIDs. So yeah, I definitely think that Tylenol gets a bad rap, but other things that we can do to encourage, healthy lifestyle, diet, exercise, limiting alcohol intake, all of these things combined will help with the management of their chronic medical condition. And again, anything that they take by mouth on a regular basis, even if they don't think that it's a medication, it's definitely something that your trusty pharmacist needs to know about so that we can run an appropriate drug-drug interaction profile.
Mm-hmm. So just going back to the chat, there were a lot of questions about bone health and choice of medications. And so, the thing I think about with bone health is that chronic hepatitis B infection and chronic hepatitis C infection, for that matter, both of them have effects on bone density and bone health, certainly. And I think more about a decline in bone density as I'm adding medications to that. And so for that reason, I don't necessarily screen for an assessment of bone density if people are just infected with chronic hepatitis. Perhaps I should, but that hasn't been my clinical practice. I'm certainly more attuned to this as we start medications and there is a more incremental decline in bone density. So for that reason, in my own personal clinical practice, I'll screen patients up front. So I'll get a bone density scan to see where they are before we start medications. And then at some interval thereafter, I don't know that there is a set upon interval. I kind of take my own clinical practice from extrapolation from post-transplant data, and I tend to do it every 3 years. But again, that's the way that I've done this in clinical practice, and sort of preparing for this, I didn't see any hard recommendations for a screening interval. And there was another question in the chat about whether I worry about this in only older women. I actually worry about it in all patients, because we are treating patients for a long period of time. And while the decline in bone density is certainly more significant in women, it can be seen in men as well. So I certainly don't discriminate, and I will screen in all my patients.
Just wanted to,
I don't know if you have a point, Dr. Madison.
Yeah, I just wanted to echo that same sentiment, that there is this thought process that bone health is really only an issue for our female population, which really isn't the case. Also, just wanted to say, that with other issues like, smoking, which is potentially more likely to be, something that a male patient may be engaging in, those are some other risk factors for bone health issues as well. And so not to, think that this is just a postmenopausal woman issue. This is a everybody issue. And from my work in our HIV positive patient population, I think that this often gets missed, especially when I think about my sexual and gender minority population. Even if I've got, somebody who's relatively younger, if they've been in care and on some of these medications, which also are used for hepatitis B and HIV, if they've been on some of these medications for 5-6 years, those medications can cause challenges with their bone health. And so it is a conversation that we need to continue to have and to discuss in our male population as well, because they can be just as likely to have a fall and have a higher fracture risk, just like our female population as well.
Great. So we're on our 5-minute mark, actually 4-minute mark. So I'm just going to take one additional question. And the question is, would you ever discontinue antiviral therapy in a patient with chronic hepatitis B infection? There are certainly times when we meet our treatment endpoints. I also think about a pregnant woman who may meet criteria for treatment in the 3rd trimester of pregnancy. And to decrease mother to child transmission, we'll start her on medication, tenofovir specifically, and then withdraw therapy in the postpartum period. So certainly there are situations where I would think about discontinuing therapy in patients. But again, I'm pretty careful with respect to when I'm going to initiate therapy in the first place. So if I don't think a patient is going to need this medication right now, if it means that I'm going to delay a treatment decision 3 months to get updated labs, then I'll do that, as long as it's not going to be harmful to the patient.
Yeah, and I would agree with that as well. You always also need to take into consideration, their likelihood to continue on therapy once you start them as well, because obviously we know that there's no cure, and sort of, are they going to be able to come back for the continued monitoring, and all of those things need to go into your decision to whether or not to initiate care.
Just speaking to that continued monitoring, so obviously you're monitoring for evidence of treatment efficacy, but you're also monitoring for concern for side effects, and so renal dysfunction, et cetera. So if you have concerns about long-term adherence, you really have to take that into consideration as you're looking forward to initiating treatment and what agent you might choose for therapy. So Dr. Madison, one last question. Can you speak to vaccination of infants? I know that has come up in the chat as well.
Yeah, absolutely. So hepatitis B is actually the only vaccination that we give at birth because it's considered an anti-cancer vaccine, as well as the fact that we know that the highest risk for chronic infection is from perinatal transmission. And so, again, that's why we have very robust perinatal hepatitis programs at our public health departments across the country. So we are actively surveilling and screening pregnant women to see if they have hepatitis B viral infection. And then at that point, we would vaccinate baby, as well as we could provide them with HBIG at the time of delivery if mom is positive and has a detectable viral load. And so again, this is just part of knowing that ACIP recommended vaccination schedule and that it's routine and recommended. The only thing I would say is that I have seen some instances where that birth dose gets missed or maybe is not done on time, especially if baby is in the NICU or if there were some other complications associated with their birth process and that hospitalization. So if baby was in the hospital for a little bit of time, they don't really focus on vaccinations. But again, there's no harm in providing that vaccine, even if baby was having some other challenges at the time of delivery.
Great. Thank you, Dr. Madison. So unfortunately, we're at the end of our time today. We had many great questions, and I'm sorry we weren't able to get to all of them. But before we go, let me remind you of the key points, our SMART goals for our program. They're to partner with patients to help them better understand their hepatitis B infection, keep a watchful eye on patients' use of over-the-counter medications, supplements, and medications for comorbid disorders that may interact with their hepatitis B antiviral treatment, communicate and collaborate with healthcare providers about patients' hepatitis B treatment plan to optimize outcomes. So I want to thank you, our audience, for all of the great questions you sent in. If any of your colleagues have missed today's program, let them know that there's another live credit opportunity available on Tuesday, June 15th at 7 p.m., and that's Eastern Standard Time. For additional clinical and patient resources, please visit CMEO Pharmacist Central at cmeoutfitters.com. Stay safe, and thank you again for participating and for providing the best care for your patients. Thank you.
Thank you very much.